Hey guys, it's kind of late in the evening. I know you just had a lab exam today, and for the most part, most of you did very well on that, taking it and submitting it. So we only have one more of those to go. We got two more lecture exams, and I wanted to review for that. With this new online, this has been crazy for us as well as you, I know. But I cannot tell you how many hours I've put in trying to get these tests on there in a way that doesn't hurt you and doesn't hurt me, so to speak. I want academic honesty, but we need to get those in. Some of you had a little trouble getting your answers in. Next time I'm not going to be able to accept them after a certain time. So it's one of those things, and it's a judgment call. It's nothing against anybody personally, but if I can't reset an exam for you, I just can't, and we're just going to have to go on. But try to take these when we're taking them. I don't know how many exceptions I can make here. But again, for the most part, everybody did pretty well submitting those. I know this is new to you as well, but you guys probably know technology better than I do. So I wanted to set a review up. We have a lecture exam again next week, and you may think these are kind of quick, but this is actually how it would go during the regular semester. It's kind of like that little engine. Like I said, we start from zero, we have a couple tests, and then down the hill we start hitting them bang, bang, bang. So I want to keep giving you reviews to help you. This will be pretty quick because these take at least 2 hours to upload. We've had to upload some of them 2 or 3 times because they'll kick them out right at the end. It's been very, very frustrating, but I don't feel good about leaving you without at least a review. That way you can kind of focus in on your study and not have to study every single detail. So let's get rolling. We're going to start with Chapter 7. Now, Chapter 7 is the skeletal system, and it's one of the longest chapters you probably have as far as PowerPoints. But if you hear anything that I say, hear this. We've already tested you on the anatomy. That's what you just took this morning. So most of the anatomy, not that I can't pull a little something off the lab and put it on the lecture, but for the most part, this is not about anatomy. So this chapter is going to be reduced to a lot smaller. So I'm going to tell you some things I want you to know. All right, let's start out here. By age 25, the skeleton completely hardens. That's for a male. A female is 23. Those are a couple good things to know. I'm not a big numbers guy, but there's a couple of numbers I want you to memorize for this test. 206 total bones in the skeleton. Good number to memorize. Doesn't make good true-false questions. All right, let's go on here. Okay, classifying bones. A long bone, I think we said this in the lab. We probably didn't get this in the lab. We didn't get enough time in there. But I think I did say this to you guys. A long bone is not classified as long because of its length. It's classified as long because it has 2 ends and a shaft. The example of that I want you to know is the femur is a long bone. Short bones do not have that. This bone B, the talus, T-A-L-U-S, it's an ankle bone. I want you to know it as the example of a short bone. Sesamoid bone is a bone that occurs within a tendon. That is the patella. This bone, patella. So that's your example for the test. These are easy questions to get on the test if you memorize them. Flat bones, generally skull bones. The example they give you is the parietal bone. Irregular bones, best example is the vertebra. And finally, a wormian bone, do not worry about that. Those occur within a suture line in the skull. I'm not testing you on those. Okay, parts of a long bone. I want you to know what the epiphysis is, or the epiphyses. Those are the ends. We have a proximal and a distal. The proximal is where the head of the bone is. The diaphysis is the shaft, so know that. What else? You know articular cartilage is hyaline cartilage. You knew that from probably Chapter 5. Periosteum is the covering of the bone. We see that cut right here. Know that the periosteum is the covering. And I also want you to know that the epiphyseal plate, we can see that word here. It's not in this, not listed here, but the epiphyseal plate is the growth plate. If we see an epiphyseal line, which is like a little calcified line, that means that bone growth has stopped in that bone. So those are good things to know for the test. All right, microscopic structure you should know for when we were in session. This was in Chapter 5. We talked about the osteon, or Haversian system, and we talked about the parts of that. And on that first lab test, the only thing I tested you on was the osteon, the osteocyte, and the central canal. What I didn't test you on is like the canaliculi. And I said I might test you on the lecture on that, and I might say something like the small channels that lead from the central canal to the osteocyte are known as what? And you would answer canaliculi, and no, you may not. That's my running joke, if you remember it. Volkmann's canals, we didn't talk about in the lab, so we're going to talk about them in the lectures. Volkmann's canals essentially are perforating canals. I'll call them Volkmann's, the proper name. They connect central canals. They connect osteons together. So they are transverse canals that connect osteons. Might be a good test question. Good pictures here. Let's go on. Okay, this is a little more difficult. I want to say this, try to make it as easy as I can. It's okay to call a bone an intramembranous bone and an endochondral bone. But in the class, if I were lecturing on this, I would have said, we're going to talk about the process. The process is how bone becomes hardened, and it's called ossification. O-S-S-I-F-I-C-A-T-I-O-N, ossification. Intramembranous ossification and endochondral ossification. That's how I approach this. Now, very simply, intramembranous ossification is how the bones of the skull and all the facial bones, I should have said the cranium rather, the cranial bones and the facial bones, which make up your skull, all of those form through intramembranous ossification, which is a hardening of a fibrous connective tissue. The only one that doesn't in the face is the mandible. So all the cranial bones and all the facial bones except the mandible become hardened through intramembranous ossification. All the other bones, the mandible and all the other bones in the body, become hardened through endochondral ossification. And we talked about this in the lab, that hyaline cartilage is what starts out as that's what bone starts out as, and it hardens to bone. It becomes more mature. So just know the difference in those two. Again, the mandible and every other bone, endochondral ossification, the cranial bones and facial bones except the mandible, intramembranous. This is a little picture of this. I usually would describe this. I don't want you to worry about this for the test. But these two terms, osteoblast, osteoclast, we'll talk about those here in a minute. Skip it. Skip it. Okay. This is where we're going to talk about osteoblasts and osteoclasts. This is actually, in the next semester in Biology 139, we have a subject called endocrine system. This is actually endocrinology, how your endocrine glands work, how your hormones work. So, this is how osteoblasts and osteoclasts work. When you want to build bone, B for build, that is osteoblast. Osteoblasts put bone down. Osteoclasts do something we call resorb bone. They break it down, but they use the calcium in it. So, if we have low blood calcium levels, the body is going to stimulate the parathyroid glands to secrete parathyroid hormone, also known as parathormone or PTH, and that will stimulate the activity of the osteoclast. In other words, if your calcium is low in your blood, you're going to break down bone. The parathyroid gland stimulates osteoclast, it resorbs bone, which means it breaks it down and uses the calcium and elevates your blood calcium back to normal. This is homeostasis, negative feedback. The opposite, if we are going to deposit bone, if you have high calcium in your blood, you don't need all that calcium. Osteoblasts are stimulated by calcitonin, which is secreted by the thyroid gland. And that is going to cause osteoblasts to build bone. So if you have high calcium, thyroid gland stimulates the release of calcitonin to build bone, also bringing calcium levels back down. This is negative feedback homeostasis again. You might look over these. These are different factors related to bone growth. The sex of someone, if females generally have lower bone density than men. Exercise increases bone density. This is probably the most important right here, physical stress. There's several things. Just kind of look over those. Skip over to here. Fractures are breaks in bones. I usually would have given you guys 4 stages of fracture healing, and here they are. The first thing that happens is you form a hematoma, which is like a big blood clot or a bruise, but it's a blood clot right around that fracture. The second thing is you form a soft callus. Soft callus forms because the fibroblasts come in and start secreting a bunch of collagen, and that forms a soft callus. Then you have a hard callus form. That's when the calcium salts come in and you form bone, and then the fourth stage is remodeling, which could take years and years. You can see x-rays sometimes of somebody have a broken collarbone or clavicle, which again is the most frequently broken bone in the body, and the callus will remain there for years and years, probably stronger after it's broken. All right, functions of bone. We didn't cover this in chapter 5 because I said we would wait till here. Here are the functions: support, movement, protection. Blood cell formation. We form blood cells in the bone marrow, in red bone marrow. That's called hematopoiesis. And we can call this mineral storage. This is just a small list of what is in the bone. If I were doing the articles for extra credit, I would have you do possibly one that says, hey, what all is in bone? Remember, you're getting your bonus for completing this class. If you complete the class, the online portion, I'm just giving you all 20 points flat. You don't have to worry about the articles. All right, let's skip over to this. Now we're starting to get into the anatomy. There are some things I'm going to give you in this, but very few, and some things we didn't cover. Again, know there are 206 bones. Let's go on. We've already covered this, so I'm going to go through this very quickly and just give you a few high points that you might see on the test. Again, this is all anatomy. Anatomy, anatomy. I'll tell you when I want you to know something. One thing that you might know is what the suture lines separate. The sagittal suture, for example, separates the parietal bones. The lambdoid suture separates the parietal and occipital bones. The coronal suture separates the frontal and parietal bones. That could be something. Let's go on here. Let's go on here. Sorry, I'm going backwards there. Let's go forward. Nothing so far. The ethmoid bone. This is the primary supportive structure of the nasal cavity. Not because of its strength, but because of its location. But primary supportive structure of the nasal cavity. Very fragile bone, actually. Maxillary bones will articulate. When I say articulate, that means to form a joint. Remember, the hyoid bone does not form a joint with any other bone. I think I talked about that in the review for the lab test. But the maxillary bone forms a joint with every bone of the face except the mandible. They don't consider the teeth an articulation. So that's something that I might show up on a test. All right, this, I don't know why they labeled this facial skeleton. It's obviously a mistake. This is the paranasal sinuses. Now this is a diagram you knew for the test, but I want you to know which bones have paranasal sinuses in them. Also know the function. I think I said this for the lab test review, but you may see it here on this test. They lighten the weight of the skull and they help to resonate sound. Very possible you see that on a test. Zygomatic bone is your cheekbone, right here in green. That might be something that shows up. I'm going to keep moving through this pretty quickly. You guys don't have these pictures anyway, and we're frozen here for some reason. Give me just a second. I'm frozen in here for some reason. Okay, let's try this again, see if it'll boot back up. Oh, please, man. There we go. All right, sorry. I'm going to move on since it's working here. Again, you may see some little tidbit of anatomy on the test that you should have already studied. You know, I may have to go through some of these exams and throw out some questions when I'm grading them. There's one more point I want to make. I'm going to step over here in the screen for just a second. Be patient on these grades. I have so many emails that have tests on them. I'm going to have to pull those up and try to make out your chicken scratch on a piece of paper. You guys did great photographing some of those, but just be patient. I'll get to them, I promise. All right, the infant skull. We talked about the fontanelles on the lab test. I think I gave you the anterior fontanelle or bregma is the only one possibility on the lab test. However, I want you to know the function for the lecture test. And the function of the fontanelles is it helps the baby's skull change shape as it passes through the birth canal. Sometimes you'll have a kid that's born looking like a cone head. We had one, but those bones will settle down once they have a few hours outside the womb. But if their head's big, that's what's going to happen. All right. I don't know. You may remember the numbers of vertebra. Remember the sacrum is 5 fused segments. This is a mistake. There are 5. Let's see what else we need here. You know, if a vertebra has a transverse foramen, it has to be a cervical vertebra. You might want to know that. The thoracic vertebra, some really good pictures in here that you guys don't have, but I'm going to skip through those for sake of time. Thoracic vertebra, what they have are a place for the ribs to articulate. Your rib is going to come over and hit that vertebra on the transverse process and also the body. Some of them will have a half of a, what we call a facet there. They'll have half of it here and half of it there, meaning 2 ribs will touch that vertebra. But just know that's something different about a thoracic. And then again, the lumbar have the biggest vertebral bodies because they're supporting more weight. Again, sacrum, 5 fused vertebra, if I would ask you that. Most of this is anatomy, so I'm just picking a few select things that I might ask you on the test. Okay, I would remember what the classification of the ribs are. Remember which ones are vertebral. That is the 11th and 12th pair. There's also known as floating ribs. Know what the vertebrosternal or the first 7 pair, they are also known as true. And the 8th, 9th, and 10th are known as vertebrochondral, and they are false. 11 and 12 are also known as false, floating, or just simply vertebral. So know those. They could show up again on the lecture. All right. There's a great picture, just not really anything for your test, but this shows you how a rib curves in and hits the vertebra on the transverse process and on the body. Very interesting. Would like to talk more about that, but we just don't have the time with what we're doing here. Okay. Whoops, sorry. The pectoral girdle, this starts the appendicular skeleton. Your book does not designate that. It goes from axial to appendicular. Now, something I do on this particular, it's a clinical thing that could be on your test. This joint here between the clavicle and the scapula is called the acromioclavicular joint, or AC joint. We find a shoulder separation at that joint. Usually a football injury where somebody gets thrown down on the side of their shoulder. It will strain a couple ligaments here and the clavicle will pop up. There's 3 grades to that, but again, the acromioclavicular joint, which is between the clavicle and scapula, we find there's separation. The glenohumeral joint, which is the glenoid fossa of the scapula, and the humeral head is the actual shoulder joint, and that's where we see a dislocation. So again, that's between scapula, humerus, and that is a dislocation. So know those for the test. Those are a couple clinical insights. Again, the clavicle is the most frequently broken bone. That may show up on the lecture test again. I want to go through this pretty rapidly. Not sure how much of this, very little of this you will know. I would know your rules about the phalanges. You have 14 phalanges per appendage. So in other words, in your right hand you have 14 phalanges, left hand you have 14, right foot 14, left foot 14. So there's a total of 56. If I say how many phalanges in the upper extremities, there's how many? 28. Lower extremities, there's 28. One hand, there's 14. One foot, there's 14. If you hear any background noise, our son is back in his bedroom singing, the youngest one, who's actually a pretty good singer, so thank God he doesn't have the door open, but you might pick up a little bit of that. All right, the coxal bones, again, I think I went over this in the review. They're formed from the ilium, ischium, and pubis, but what is also formed is the acetabulum, where the head of the femur is going to articulate. So I want you to know that the acetabulum is formed from the union of the ilium, ischium, and pubis. Good test question. Difference between male and female pelvis, I think we did this for the test. I don't know if this will be on your lecture test, but greater than 90 female, less than 90 pubic arch is a male. I'm gonna have to tell him to shut up. I can hear him. All right, lower extremity. I guess I can drown him out. The femur is the longest, strongest bone in the body. That's a possible test question. This is the weirdest looking femur. This is the smallest pelvis for the largest femurs. I think they screwed that up a little bit. Again, the patella, we talked about that being a sesamoid bone. Again, just want to make a point here. The hyoid bone, we said, is the only bone that does not form a joint with another bone, does not articulate. The reason the patella does, it seems like it's out here just floating in front of your femur. It actually has an articular surface on the back, and that actually glides against the femur. So it actually forms a joint there. You know what? I think that's probably about it in that chapter. Most of the rest of this is anatomy. In fact, I'm going to get out of that chapter. Try to shorten this up because, again, this will take every bit of 2 hours to upload to YouTube. And the last couple times my wife's done this all for me. Thank God, she's filming me right now. But she's had to do it at least twice every time. It kicks you out right at the end. It's just really, it really stinks. I really wish it's, you know, from that point we were all meeting in person. It's just I'm not an online instructor, but we're trying our best here. I know everybody's in the same boat. All right, chapter 8 is actually a little chapter on the joints. We'd actually call it arthrology. And I'm going to do this very short and sweet. I used to do this as matching. These will be multiple choice. But here's a few things to know. A joint is an articulation. That is a functional union between bones. Know the definition. We're going to classify these different ways, but I'm going to make this very easy. I'm going to go over a classification. The names are hard, but I'm going to give you one example of each to make it very simple for you and hopefully very user-friendly. But you got to put the time in as usual. So we're going to classify them 3 ways. Again, I don't want to sit here and lecture, but we have a dual classification. A fibrous joint is also a synarthrotic joint, considered to be immovable. I'm not going to go into that, but I believe they move. Cartilaginous joints are slightly movable. They are amphiarthrotic. Synovial joints are diarthrotic, freely movable. We're probably not going to ask anything about this right here. But these, we're going to give you some examples of each, and hopefully I'll make it really easy for you. So then we have different, it's really not like it says, there's 3 classifications, but then we have other types within that classification. So fibrous joints, there's 3 types. Syndesmosis, what I want you to know is the interosseous membrane, and that is right here between your tibia and fibula. This is a very misdiagnosed condition where, you know, people will, I've heard a lot of trainers that really don't know much out at a football game or basketball game, and they'll tell somebody they have a high ankle sprain because they see swelling kind of high in the ankle. That does not mean they have a high ankle sprain. A high ankle sprain is a disruption of this membrane, and it is very painful and it's very hard to heal. So a syndesmosis is that interosseous membrane. A suture, I just want you to know a suture is a fibrous joint. We saw, those are between, you know, this is a dry skull. So this is dried up. If we saw this as a living skull, this jagged edge here would be a fibrous membrane, the same fibrous membrane that hardens to form the skull bones and the facial bones. So if you hear suture, just think fibrous. Gomphosis is the tooth in the socket. It's the periodontal ligament with the tooth. And I've had 4 of these pulled in the last couple years, so believe me, I have some experience with this. So those are your 3 fibrous type joints. This shows you the suture lines. Nice picture here. Cartilaginous joints, 2 types. Synchondrosis. Chondro means cartilage. Synchondrosis is hyaline cartilage. Symphysis is fibrocartilage. You know one symphysis, and I'm not going to give you the one you know. But synchondrosis, I want to give you the example being the growth plate, the epiphyseal plate. Even though it's a temporary joint, it's a great example of a synchondrosis, which is hyaline cartilage. The symphysis, you were already tested on the pubic symphysis, but the intervertebral disc is also a symphysis. fibrocartilage. So I want you to know it as being a symphysis, intervertebral disc. Hopefully this is making it a lot easier. Synovial joints are different. There's free movement. I want you to know some of the characteristics of them. One, they have a capsule. They have a synovial membrane and synovial fluid, which is basically blood plasma. They may or may not have a meniscus or bursa, but there's a joint cavity, there's a capsule, there's a synovial membrane that secretes the fluid, and then usually there's articular cartilage, in this case usually hyaline cartilage. That might be an E question. Pick all the above on that one. All right, different types of synovial joints. I'm going to put my arm out here in a minute, but I don't want you to focus on biaxial, or multiaxial, but a uniaxial joint is a joint that has motion in one plane. So I'm going to show you motion right in this plane. But there's two motions, here and here. That is a hinge joint. An example of a hinge joint is your elbow and knee. They are uniaxial. A pivot or trochoid joint, this is a long name, but it is the joint between atlas, which is the first cervical vertebra, and axis, the second cervical vertebra. I'll show you some pictures of those later. But that is a pivot joint. Remember, you can turn your head at that joint, but I will call it the atlantoaxial joint, is a pivot joint. Again, hinge joint, elbow and knee. The biaxial joint, saddle joint or sellar joint, we see at the thumb, right here. It has movement this way and that way in two axes. A condylar or ellipsoid joint are the knuckles, but we call the knuckles the metacarpophalangeal joints. Metacarpophalangeal joints, the union between the metacarpal and the phalange. Multiaxial mean they have movement in every plane of motion. So these are like your ball and socket joints, and I'm sure you can figure out where those are at, the shoulder and the hip. And gliding joints, some of you may not think about this, but your wrist, I'm going to hold my arm here, your wrist has movement in any plane, and those bones in there just glide across each other. So we call these intercarpal joints, are gliding. Ball and socket, hip and shoulder, condylar or ellipsoid, metacarpophalangeal, saddle joint, thumb, pivot, atlantoaxial, hinge joint, elbow and knee. Here's some pictures. I think you guys have these in your book. I would look at these. These are interesting. It shows you where those joints are at, some of them. And I'm pretty sure you have the mechanical drawings too. So these are really interesting. Okay, finally, I don't want you to pay attention to these. These are more muscle terms. We'll do that in the last chapter, chapter 9. These will be on the next lab exam. I will use pictures. I'll do a review for that, but log it in right here because I won't have these pictures when I review for the lab. But see how this shows two motions, flexion and extension. This we may not use, dorsiflexion, plantar flexion, abduction, adduction. I'll use these on your lab test too, because these will be tested probably on the lab and not so much on the lecture. But if they are on the lecture, there might be a couple of them, so I want you to know the terms. Here's the anatomical terms. In fact, go on Blackboard and look up your muscle packet, and these are defined. I'll let you look them up because that's going to save a little time. And again, this will take 2 hours to upload. But they are typed out, and they are defined how we define them in anatomical language. For example, you know the term flexion and extension, but in anatomical terms, we say flexion is decreasing the angle of the joint, extension is increasing the angle of the joint, hyperextension is beyond extension. And they show it at the wrist where it's not going to hurt you at the wrist. If you do that in the elbow, it hurts you. So look those up in your muscle packet on Blackboard for the lab. They should all be defined for you. And I'll leave it at that. I'll let you look those up. The rest of this is just FYI. If you want to look it up, this is how I always do it in lecture. It just shows you some of these joints and some of these surrounding. You may or may not have these cadaver pictures. So I usually do a case study on this with you just for fun, but We just don't have that luxury. So that's the end of this chapter. I'm going to go on to chapter 9, which is the muscle, and finish this review up. And again, hopefully this will help you guys, again, to narrow it down. I just can't bear to do this without narrowing it down a little bit for you. Some of you love this online, I think. Some of you, a lot of you hate it. But I think some of you really thrive on this because, you know, if you're a self-starter, this is going to be pretty good for you. My goal is to let you guys work ahead, so I'm probably going to, at least by tomorrow morning, I'm going to go ahead and open up the third exam. I would suggest that you look at the review first, and hopefully we can get that on tonight. If not, it'll be tomorrow morning. But I may make that available after I get the review posts. And so I would suggest check out the review before you go in and take the test. But that's up to you if you want to work ahead. The lab test, I just can't find a way for you to do that right now. All right, some of this chapter 9 should be review. We talked about chapter 5. I told you at that time to save that little chart that we did for the muscle in the tissues. If you remember that, I asked if they were uninucleated or multinucleated, striated, non-striated, voluntary, involuntary, branched. That will help you here. I may ask a bunch of multiple choice questions that say, here's an example of a question. The choices are A, skeletal, B, smooth, C, cardiac, D, 2 of these, E, none of these. The question might say, which of the following is voluntary? That would have to be skeletal. Which of the following is involuntary? That's going to be cardiac and smooth. Which of the following is involuntary and uninucleated? Also cardiac and smooth, 2 of the above. Which of the following is involuntary, uninucleated, and striated? Cardiac muscle. So you get the idea. I can use that chart to ask you questions based on these. So let's go on here. Something we didn't define, we may have defined it, we went over in chapter 5, the term tendon, ligament, and aponeurosis. I think I defined those in the lab, but I'm going to define them again. Ligament is kind of out of place in this chapter because a ligament joins a bone to a bone. That's the definition. A tendon joins a muscle to a bone, and an aponeurosis joins a muscle to a muscle. It's a sheet-like tendon. So we have a big aponeurosis on your head. We talked about that in the lab. So again, those are your definitions. You will see those on this exam likely. Terrible picture here. Hopefully you can understand the picture. The muscle has little divisions. We showed you what a muscle fiber looked like, a skeletal muscle fiber, on the tissue slides. Each little muscle fiber, what we call a myofiber, was covered with something we call endomysium. It's a connective tissue. Then we have groups of muscles that are covered by paramysium. That group is called a fascicle. And then we have all those fascicles, all those groups together, and are wrapped with epimysium. So it covers the entire muscle. Here's a good analogy for that. If you go to the cafeteria and get a straw, or go to Wendy's and get a straw, think of that straw as one muscle fiber. It is covered by the paper on the straw. That is your endomysium. If you grab a handful of straws and you wrap tissue paper around those, that is like a fascicle, and it is wrapped with paramysium. And then if you take 3 or 4 of those bundles of straws and wrap those with tissue paper, that is your epimysium. Hopefully that helps. Something down here that we introduced down here, and again, this is something I quit testing on a few years ago, so this is not shortening it for your benefit. We have thick and thin filaments in skeletal muscle. And there's a couple of things that we talk about. I'm going to go ahead and pan forward here a couple slides. Okay, we talk about contractile elements or contractile units in the muscle, and we call them sarcomeres. That is not something you'll probably see on the test. For years I had to teach these and people learned them, the different areas of the sarcomere. And what I'm going to say is very simple here, and it could boil down to one question. We have thin protein filaments, we have thick protein filaments. We have thin filaments called actin, we have thick called myosin. If you remember, skeletal muscle, cardiac muscle is striated. It is striated because their fibers are more straight oriented. The smooth muscle is more of a fusiform shape. If you remember, I drew that on the board in the lab. That's why their fibers do not line up. The striations of the muscle, here's the point. The striation of the muscle is caused by the overlapping of the protein filaments in it. So for example, in this picture, right here, you only have thin filaments. Here we have thick and thin. Here we have thick only. Here we have thick and thin. Here we have thin only. That's what makes up one sarcomere and all these bands and zones. You do not have to know the bands and zones. What if I ask you a question that says the overlapping of the thin and thick protein filaments in a muscle is what is responsible for its striated appearance? That would be a true statement. So something to that effect on the test is all I want you to know about that. Another thing about the muscle contraction. This is representing a thick filament, this lighter purple. These are thin filaments. Calcium is of utmost importance in muscle contraction. When calcium comes down into the muscle, these thick filaments, which look like they have little arms here, reach up and grab the thin filaments, and then they move them together. This is what is known as the sliding filament model. When I was in college, they called it the sliding filament theory. I don't want you to even know about that for the test. I just want to mention it, but we're not going to test you on it. And there's several slides coming up on that I think are just something you don't need to know. Now, these you do. This is where we start. I get excited. I would get excited if I were lecturing, because this is where we start coupling the nervous system with the muscular system. Because your last lecture exam, remember, is over only chapter 10 and 11, which is nervous system, but it's a lot of stuff. And I'm going to give you a document. I'm going to make it available on Blackboard at that here pretty soon. That will help you on that last exam. It's going to narrow things down, and I give it every semester. But the neuromuscular junction is where a nerve, a branch of a motor neuron, and the muscle come together, so to speak. But they do not touch. It's very important. There's a space in between them here. Here's the space. Here's the end of the neuron. Here's the muscle cell membrane. So when we want to stimulate a muscle to excite it, we have to release a chemical which will cause the impulse to go across and stimulate that muscle. That space is called a synapse, and that chemical, all these little dots here, are granules of something we call a neurotransmitter. So as the impulse comes down the neuron, we actually have calcium also comes into that neuron, and it causes it to release all these little granules. And then the nerve impulse can jump across. It's much more complicated than that, but that's what we're going to say. So the motor neuron is what stimulates the muscle. The motor end plate is on the muscle. There's not an X marks the spot. There's not a plate there. It's just the area of that muscle cell membrane that you're stimulating. The synapse is the space. The synaptic cleft is, the synapse is the whole thing, but the synaptic cleft is the space. And the neurotransmitter is what jumps across that space. Vesicles are what that neurotransmitter is stored in. If you remember way back in chapter 3 and 4, we talked about a vesicle that is pinched off of the Golgi apparatus and filled with a protein, and it can go to the outside of the cell and undergo exocytosis and release something outside the cell. This is what's happening here, exocytosis. So hopefully that you'll remember that. But I would know a basic definition for these that I just gave you. And again, they do not touch at the neuromuscular junction. They have to have that chemical. One other thing, a motor unit is one motor neuron branch and all the fibers it supplies. And this is very important. Look at this picture. Here's motor neuron 1, and motor unit 1 supplies this fiber, then it skips to this fiber, then it skips to that fiber. Why is that very important? Because we can do things like this and that. You can see my filthy hands. I've been outside doing some work tonight. But this fine manipulative movement is what allows that. It may not supply every fiber right in line. It picks and chooses sometimes. But again, a motor unit is one motor neuron and all the fibers it supplies. A lot of times this is what twitches when you get a twitch contraction. The chemical that's released here to stimulate muscle is acetylcholine. ACH, we sometimes abbreviate that. It is an excitatory neurotransmitter, meaning it excites something. Versus an inhibitory neurotransmitter, we've talked about serotonin and its ability to help you sleep. It is not excitatory, it is, what's the word I'm looking for? It is an inhibitory neurotransmitter. That's why it causes you to be calm and to sleep. Skip that there. Don't worry about any of this. This has to do with the thin and thick filaments grabbing together and sliding together. The sliding filament model. I do want to show you something here. Here's the muscle relaxed. Here's thick filaments, thin filaments. Here's the muscle contracting. The thick filaments have these little arms that reach up and grab the thin filaments. Here it is fully contracted. It shortens. That's why the muscle shortens when it contracts. Usually. Skip it. Skip it. Skip it. We're skipping all that. Skip. Skip. That had to do with cellular respiration. We've already talked about that way back when. So does that. All right, muscle fatigue. This is worth mentioning. I don't know if it'll be on your test, but some of you have experienced this. But you can have this because you don't have enough blood flowing to the muscle. You can have, say you don't have enough calcium, potassium, sodium. We'll talk about potassium, sodium in the nervous system, but those all have a role in not only nerve control, nerve function or propagation, but also in muscle contraction. Let's go on. Go on. Go on. Skip it. This is all neuro stuff. We can cover some of that in 10 and 11. So I want you to skip all the way over to here. Types of contractions. Okay, there's two types. I don't like the way this slide is. There's two types we're focusing on here. Isotonic and isometric. Iso prefix means the same. Isotonic means the same weight, basically. Excuse me. The same weight throughout the motion. In other words, if I do this motion here, I have the same resistance throughout, whether I'm shortening or lengthening the muscle. So there's two phases to an isotonic contraction. Concentric is the shortening contraction. Eccentric is the lengthening. So if you look at this person doing a curl, when they curl up, flexing the joint, they're shortening the muscle. When they put the weight back down, they're lengthening it. This is something that people forget in the gym all the time. Another reason I never like to hang around in gyms. You see people doing the bench press, for example, they put the bar up in the air, and when they go down to touch their chest, that is actually I believe the eccentric contraction. But they'll just let the weight fall down on their chest and slam it off their chest and then shove it up. So they're missing one whole part of that contraction, just like in curls. You've seen people curl going, ugh, ugh. You're wasting the entire lengthening contraction to build the muscle. I love these. My father told me about these a long time ago, and I'm going to jump up in the screen. If I was in between a wall, that I could hold my hands against both parts of that wall, which I can do that at Tech Drive. It's perfect in the room I teach out there. And you push against that. You're not lengthening the muscle. Iso, again, is the same. Metric is the same length. So this is a contraction where the muscle doesn't change length. Very, very effective contractions. I think we might have some technical difficulties. All right. I'm not going to mention these. I would in the lecture. Skipping over to this. Again, know the characteristics of your muscles. Look at that chart from chapter 5 from the tissues. I'm going to skip through these. That's what I want you to know about the characteristics. We're not going to talk about the high school science here. I do want you to know this. Origin and insertion. Origin is the connection of the muscle that doesn't move. The insertion is the movable one. They're giving the example of the bicep. The bicep origin is up here. It actually has two because it has two heads. One is on the coracoid process and one is in the bicipital groove of the humerus. The insertion is down here on the radial tuberosity, something you didn't have to know. You didn't have, I didn't say that during the review for the skeleton, but we didn't even scratch the surface of things to know for that. I know it seemed like a lot, and I even cut it down on the review, but we didn't scratch the surface. But this part moves. Right here is where my bicep is attached. if you do this at home, feel right there, it'll be sore as a boil if you use it. When I contract that, this is the end that moves. So here's the insertion, origin up here. All right, I want you to know these terms. Agonist. This is the muscle that does the bulk of the movement. So let's take the bicep again. This action, flexing the forearm. The prime mover or the agonist is the bicep. The synergist would be like the, the brachialis muscle in here. Helps the biceps do that, but the biceps is the one that does it. You can tear your bicep and still do this motion, it will just be a lot weaker. So the synergist helps the agonist. The antagonist is what resists that motion. So if I flex my forearm as hard as I can, my tricep is actually resisting that. It is the antagonist to that movement. So know those. This one, you don't need to know it, but I'm going to tell you what it does. When you contract the muscle here, there are muscles that stabilize the origin so you don't tear that tendon. Usually when people, all you that like to carry in all your groceries when you go home at one time, carrying the groceries in may not be harmful. It's when you try to move side to side because you are overworking a fixator and it will snap your tendon. The rest of this chapter, believe it or not, will be more lab stuff. It's all just pictures of muscles. I will give you certain muscles to know for the lab. So this is the end of this chapter and the review. Again, this test, I'll probably put it up sometime tomorrow. It's not due. It's due on different days for different classes, but it will be next week. So, you know, if you want to work ahead of a couple days, if you have time, because of the being quarantined or whatever in your home, you can do that. But we'll try to get this review posted tonight or at least by morning. So talk to you all later. Thanks.